Hello, everybody. I'd like to welcome you to the breakout session entitled Alleviating the Progression of CKD, Proactive Nutrition Strategies. Our speaker for today is AnnaMarie Rodriquez. AnnaMarie has worked as a renal dietitian for over 24 years in a variety of settings, including clinical, sales, education, and renal medical affairs. She's currently an independent consultant, the owner of Nutrition Directions, LLC, and employed by Pentec Health. She has served and chaired several boards, including NKF activities, local CRN groups, the Renal Practice Group, and is currently chair-elect for the Vegetarian Nutrition DPG, on the Academy's Quality Management Committee, the Southeast Region Representative-elect for the Wisconsin Academy, a board member of the Plant-Based Prevention of Disease Organization, a state coordinator with for the Vegetarian Nutrition DPG for multiple states, including Wisconsin and California. She's a master gardener focusing on higher education, in addition to peer reviewing, authoring, and co-authoring additional projects related to CKD, plant-based nutrition, and nutrition support in CKD. We're all very excited to hear what you have to say, AnnaMarie.
Thank you so much. It's an absolute pleasure to be here, and I'm honored to be able to present today and to talk about one of my very favorite subjects, nutrition, and to alleviate the progression of CKD. My disclosures, we already know what those are, and we don't need to talk about the objective because we are going to dive right in. And you might feel like I'm going to race through the topics, and I won't cover every single word that is on the slides, but rest assured, you're going to have copies of the slides, you're going to have the handouts, and I've included a reading list of every single citation and reference and more, so that you will have plenty for your reading pleasure. And to get started, you might be wondering, what exactly is a plant-based diet? And there are many, many different terminologies at this time. And this has taken a lot of different directions because there's so much variety. But if you really think about it, notice too, the DASH and Mediterranean lifestyle, that's plant-based. But I want to draw your attention to the Plato nutrition plan. It's a plant-dominant, low-protein diet for patients with kidney disease. And that's what we'll talk a little bit more about. I want to draw your focus to that because it's a little bit more liberal and for good reason. We'll talk about impacts stemming from the new nutrition guidelines and why is this so important. It's important because, as you can see here, CKD is not going away. The prevalence, the incidence, it's continuing to increase at a very alarming rate. And we might wonder, why is this? It's because we have an aging population, we have an obesity epidemic, we have increased incidence of diabetes, of hypertension, all of which can be alleviated through what? Nutrition, of course. Yay, dietitians. And future interventions thus should be directed to preventing the progression of CKD. All of those factors can be impacted by us, by dietitians, intervening with our patient care. I urge everybody to take a moment to go to minuteforyourkidneys.org. It only takes 5 minutes. Assess your risk because 33% of Americans are indeed at risk for CKD. And in 2018, Carolyn Christ wrote that patients with CKD could slow the progression of their illness and delay dialysis through nutrition therapy. Why is this important? Because 10% of patients with CKD non-dialysis actually meet with a dietitian. And this is very important because we're looking at a population in our country that CKD affects, 15%. And Dr. Kramer stated that kidney disease should be viewed as a nutritional disorder, but unfortunately it's not often seen that way. And an abysmal number of patients even see a dietitian. We must focus on nutrition in a global manner as well. Most dietitians that know me know I always say basically 3 things. We as dietitians must be proactive, we must be strategic, and we must be global. And that involves attacking nutrition from a perspective that embraces all of the parameters that affect our patients. And when I look at this graphic, I look at all of the different components that affect our patients at any given time when they're affected with CKD. any given moment, our patients are affected by any number of these because they're facing, as I said, it's an aging population, they're facing anemia, acidosis, often comorbid conditions. They have endocrine disorders. All of these affect inflammation. And then when they eventually go on to dialysis, if they do, they have these dialysis factors that are related, volume overload. Every single one of these affect inflammation, which impacts their dialysis related factors in the long run and their nutritional status. Inflammation plays a big role with nutrition, and we must take into consideration how can we alleviate that through nutrition. Protective effects of the plant-based nutrition is one way, and it's very effective and affordable. We must look beyond the nutritional guidelines that were published because they don't really talk too much about plant-based. And we'll talk a little bit more about that in just a moment. You might also wonder, is there data to even support this? And yes, absolutely, there is. If we look at the Tehran lipid and glucose study that was published in 2014, note participants in the highest quartile plant protein intake exhibited 30% lower risk of CKD. And this is not new news when we look also at the MESA data, multi-ethnic study of atherosclerosis. This is older data. This is from 2008. So this is not new news, but note high intake of whole grains, fruits and vegetables, low-fat dairy. This was associated with lower urinary albumin-creatinine ratio. And you might wonder, well, is this it? No, it's not, because there's a lot of larger data. Note the Singapore Chinese Health Study. This is very large population of 63,000 participants with a median of 15 years. And note the highest quartile red meat intake had 40% increased risk of developing CKD. And this was documented by Liu et al. In 2016. And also too, the ERIC data with greater than 12,000 participants, 23 years, the highest intake of nuts, legumes, low-fat dairy had a 19% lower risk of CKD. And when we look at additional data of red meat and processed meats, which is very detrimental in the Western society, that increased the risk of CKD by 23%. This was documented by Herring et al. In 2017. So this is rather new data, and additional data we don't have time to dig into, but you can see this on the reading list. So you will have access to this, and you'll be able to dig in at your leisure, if you have leisure. So let's move on. And there's not a lot of heavy, hard-hitting data. When we look at how does the amount of protein ingested impact CKD, but there are some small data, 3 randomized controlled data trials, but they're very small in sample size. There are less than 50 participants. So I would like to see more juicier data, but they all had type 2 diabetes, they all had albuminuria, they ranged in duration 7 weeks to 5 years. But what is important about this data is all of these studies identified significant reduction with albuminuria with just partial replacement of animal protein with plant protein. Why is this important? Because not everyone's on the same food journey. Not everyone wants to be a vegan like myself. Some people want to just make some food swaps. And this is very critical because we must allow people to make choices that fit in their lifestyle. So simple changes can make very significant impacts. And why is this important? Because we know that acidosis is shown to increase endothelium-mediated tubular interstitial injury, quite a mouthful. And also too, we know that there's increasing evidence that shows that dietary acid load is impacting the progression of kidney disease. And so when we look at data by Garay, we know that all of this data that has been published by this author in CKD stages 2, 3, 4, and this is not all of this, this author has published data even beyond this, all shows the very significant effects of just adding fruits and vegetables to the intake. Look in stage 2, increased fruits and vegetable consumption produced similar reductions in urinary NAG, which is a dietary acid, and albuminuria, as did the sodium bicarbonate. And in stage 3, Patients were randomized to either sodium bicarb or fruits and vegetables for 3 years. Nice long-term data. And both groups had similar outcomes in glomerular filtration rate, GFR, which shows measure of kidney function. And in stage 4, patients were randomized to 1 year, and they also randomized to sodium bicarbonate or fruits and vegetables, and still the GFR did not differ from baseline to 1 year. What's not shown here is that patients were also randomized to their own discretion to either no intervention, fruits and vegetables, or to bicarb. And the patients that utilized the fruits and vegetables had improved lipid profiles, improved blood pressure, and still no changes in the GFR. So there's something to be said about this very easy, simple tactic. And when we look at acidosis, we must also think beyond the simple fact that we know this is contributing to the progression of kidney disease, but it also has an impact on skeletal metabolism, insulin resistance, and protein energy wasting. So we must think it's not just a singular matter. It goes beyond that. And why is this? It's because of the non-volatile acid production in the body that comes from the diet, especially our Western diet. Unfortunately, our Western diet favors a very heavy protein intake. And it's not just about a heavy protein intake, it's about a heavy protein intake of animal products. And why is this so detrimental? It's because the acid forming that's due to the organic sulfur that's found in the amino acids, such as methionine and cysteine, and it's oxidized to sulfate. Whereas the plant-based foods have a natural alkali, and it's such as citrate or malate, and that's converted to bicarbonate. And noted in NHANES 3 in about 1,500 adults, there was a significant increased risk for kidney failure in those that had highest intake of dietary acid load consumption. We must look at this. It's nothing to be ignored. And noting also too, when we compare acidity or alkalinity of diet, again, this is no new news. The net dietary acid load is determined by the balance of acid forming and base forming precursors in the diet. Foods that are high in dietary acid are those protein foods of an animal origin: cheese, meat, eggs, dairy. These produce high endogenous acid production, NEAP, whereas foods from a plant source are rich in alkali precursors. And you'll note that persons who follow a vegetarian diet, they often have low or even negative NEAP. In fact, a patient that has who has CKD, they're not able to eliminate that acid. They will have a higher NEAP, even if they follow more plant-based. So it's very important that they eat more plant-based because they can't eliminate the excess acid. And note also too, potential renal acid load, PRAL. That indicates the correlation between diet and acid-base balance. Foods that are 0 or less increase the alkalinity. So we must look towards the 0 or less to increase the alkalinity of the diet. Pro tip, you'll notice I have pro tips throughout our discussion. Balanced nutritional intake with ample fruits and vegetables with minimal animal protein intake. Like I said before, not everybody wants to give up their protein intake. Not everybody wants to eat just produce. So if some of your patients don't want to go down that path, at the very least, get them to eat more fruits and vegetables to balance that out. Let's begin our journey with plant-based nutrition. There are some myths with this. And one of the most common myths is that, oh my gosh, if you eat just plants, how are you going to get protein? But this is not true, that you won't get enough protein, because there are plenty of studies and data that show that those following a vegetarian and even a vegan diet will get ample protein. They'll meet their minimum requirement for protein and the RDA for essential amino acids. And another myth that we note is that the antiquated method of measuring biological value of protein quality. The reality is all foods contain essential amino acids, including plants. And the difference is, well, except Jell-O, tryptophan is lacking. The differences is the content, the digestibility, and the availability. And this is demonstrated in RAND data published decades ago in 2003. And this was a meta-analysis of nitrogen balance studies and found no significant differences in the protein needs that was due to the source of the protein. And another myth is protein complementing myth. The body is capable of maintaining a storage pool from hours to days. We do not need milk with cereal or beans with rice. Now we know that some nutrients are enhanced, the absorption is enhanced with other nutrients such as vitamin C and iron, but we don't need to think like that in terms of our amino acids, because our body has a pool of amino acids. When we need to build, we will draw from what we need when we need it. It's specific. The key is a well-balanced, diverse diet. And we must continue to think through, is a diet overly restrictive? Because that's the key. That we would think that patient might be missing out on key nutrients. In regards to the term biological value, the preferred terminology at this time by the World Health Organization is protein digestibility corrected amino acid score. This measures the protein quality of a specific food group based on comparing the amino acids of that food against a standard amino acid profile. And you can see in this chart that there's plenty of plant-based foods that have ample amino acids that your body can utilize. All right, switch gears a little bit. How much protein do our patients really need? And this is taken exactly from the guidelines that were published by Kadoki in 2020, sorry. For patients who are on dialysis, whether it's hemodialysis or peritoneal dialysis, the prescription should be 1.0 to 1.2 grams per kilogram based on body weight. Maybe a little bit more if a patient has diabetes to maintain glycemic control, and that is opinion. And in the instance of patients who have CKD 3 to 5, not on dialysis, then the recommendation is 0.55 to 0.6, a low protein diet, or a 0.28 to 0.43 grams per kilogram with keto acid analogs. Keto acid analogs are supplemented to keep a body in nitrogen balance to meet that 0.55 or 0.6 grams per kilogram. So you really want to get to that point to stay in nitrogen balance. But for those patients who are CKD stages 3 to 5, not on dialysis, who have diabetes, perhaps a little bit more protein to stay, to maintain their glycemic control. And this is again, considered opinion. 0.6 to 0.8 is a normal protein intake. But what I want to point out is that this guideline of low protein diet and very low protein diet received a score of 1A. And what does that mean? It's highly recommended. Therefore, this is a very, very strong recommendation. And in regards to the protein type, there was insufficient evidence to make conclusions about the effects of protein type, plant versus animal. What I want to point out is that the guidelines utilized material up to 2016, and there's data before them, but not sufficient, and there's data since. So we should make astute clinical judgment to identify how these foods can fit, because they can. All foods can fit. And that's an old Nutrition Month slogan, by the way. I love the National Nutrition Month slogans. So I did mention keto analogs too, by the way. And you might wonder, what exactly is a keto analog? Well, if you are wondering very strongly, there's a couple articles that will be coming out very soon in the journal Renal Nutrition, and you will be able to dive right in and read to your heart's content. But a keto analog is simply an amino acid that just lacks the nitrogen component. Historically, keto analogs have been available largely as tablets and only by prescription in the United States. They were not readily available. And the dose was about 6 tablets a day. And now they are readily available in the United States, not by a prescription, and also tablets and powder. The newer powder is available, it's 2 to 3 scoops per day, and that's taken in a little bit of water or juice with or without meals. And what's important to note is that 1 scoop replaces 3 to 4 keto analog tablets. And in regards to this, you might wonder, keto analog tablets have been around for 40 years. And this is a very progressive approach to delay the progression of CKD. It received a high ranking. Why isn't it used? It's very appealing. The availability historically has been a factor towards use, but now it's available. So why is it not being used? It's very cost inhibitive. Our patients oftentimes don't have the funds to pay for the keto analogs, but there's also a broad deficiency of knowledge. And with that comes a hesitancy to use. But I do want to talk a little bit about the dosing. Wu et al. Indicates a mean daily keto analog dose of 5.5 tablets with a low protein diet. And yes, you heard that right, low protein diet, not very low protein. And this was a therapeutic strategy to slow the progression of CKD. And after a follow-up of about 1.5 years, the risk of initiating dialysis was decreased by 46%. But I also want to point out by Zane et al., this using a very low protein diet plus keto analogs was useful in conserving residual renal function in incremental twice weekly dialysis. Why is this important? Because it demonstrates the simple fact that we must use our judgment depending on the patient's renal or kidney function and identifying what is the best strategy for the patient. And keto analogs can be useful throughout all of these stages. And what I want to point out is that in the guidelines, it states an individual who is metabolically stable may benefit with this approach. Well, what does metabolically stable mean? This would indicate a patient who is very stable, who has not been in a hospital, who hasn't had a severe weight loss, who does not have cancer, even who doesn't have uncontrolled diabetes. So we must consider all the facts when we're determining the best approach for a patient. If a patient is not stable, perhaps we should think a little bit higher protein, such as 0.6 to 0.8 grams, which isn't really a high protein and it's not really higher, it's actually normal. But perhaps this approach would be better, such as the Plato nutrition plan, using about 50% plant-based sources. And then as the patient stabilizes, then transition to a low protein diet. And then as the patient stabilizes even more, to a very low protein diet plus keto analogs. But let's focus on another factor here, because it's not just about the patient's stability, but it's also dependent on the patient's readiness to change. We must think in terms of the patient's individualized approach. This is a more realistic approach. We must think, what is the patient willing to do? What is the patient able to do? And modify that approach accordingly. So not only the stability factor, but the patient's readiness factor. And point of fact, the only protein modified diet is either a very low protein diet or a plant-based diet. So think about that. In looking at the plant dominant low protein diet a little bit more, this is a low protein diet. As I said, 6.6 to 0.8 grams per kilogram per day. And this is what I want you to take note of, greater than 50% plant-based protein. And of course, a plant-based diet is generally low in sodium and very high in fiber. But why is this so important? Sometimes I think that if we are talking about so many different ranges of protein, it may be very, very confusing to a lot of healthcare providers, because we want to do the best thing for the patient. So why are we talking about so many different factors? And just recently in International Society of Renal Nutrition and Metabolism, Dr. Kistler stated that we should streamline this approach and use 0.6 to 0.8 grams per kilogram in utilizing about 50% of high biological value protein. And part of me says, that's a very good approach. And it would make it easier. It would be streamlined. It would be more beneficial. But then part of me says, no, it's not a good idea. And why is that? I like the streamlined approach. I think it's easier. But on the other side, I think we must always be cognizant of the fact that one size never fits all. And also, too, I already stated the obvious regarding biological value. And then brings me to this point right here, 50% plant-based protein. Why is this? I already talked about the alkalinity of the diet and the alkalinity in being renal protective, kidney protective. Pro tip, alkaline intake is kidney protective and allows greater flexibility. And when I read a lot of the literature that talks about the dietitian's role in regards to medical nutrition therapy and low protein diets and every single component that has to do with CKD 3 to 5 non on dialysis, it all alludes to the fact that dietitians are necessary and we're underutilized. We are so greatly needed, and it's an underserved population, but it relies heavily on the fact that we need dietitians who are trained not just in plant-based nutrition, but in CKD, non-dialysis, CKD period, but in behavior change counseling and in telehealth. And we need telehealth as a tool, not just pandemic. We need it post-pandemic. And we don't need telehealth as a tool for us. We need telehealth as a tool for our patients, because this tool makes our patients' lives easier. It helps promote ownership. It helps them with self-management in their own care. And after all, it's all about helping them with quality of life. And when we talk also too about this plant-based regimen, I mentioned earlier that our patient population is getting older. They generally are 65 years and older. And once they are facing CKD, this becomes a catabolic process. They are facing inflammation, they're facing many detrimental factors, and they are exposed to this term inflammaging. This term reflects on the reduction and the ability to cope with antigenic, chemical, physical, nutritional stressors. They have increased cytokines, increased pro-inflammatory markers. How do we combat that? What can we do to combat that? Where are the bioactive compounds coming from to help fight that inflammation? The powerhouse is in the fruits and vegetables. And we know also too that fruits and vegetables have the strongest effects in preventing cardiovascular disease. There's a nonlinear threshold effect of 800 grams per day. That's documented by Wallace et al. In 2019. And how much does that equal? 5 a day. As a dietitian, when I hear 5 a day, I cringe, because we need 7 to 13. We need to eat that rainbow. But hundreds of epidemiological analysis provide this consistent evidence that fruits and vegetables exert this protective effect against cardiovascular disease, but not just against cardiovascular disease. The pro tip, 5 a day is not just cardioprotective, it's kidney protective. We're going to move forward and look at the benefits and perceived barriers of a plant-forward approach. And this section, I sometimes feel like I don't really want to talk about this, because I feel like everybody knows it, but not everybody does know it. A lot of our dietitians are new. They're new to renal, and they're new to CKD, and they want to know more. They're still learning. And even dietitians who have worked in the field as long as me say, I want to know more about this. So when we're talking about plant-based nutrition, many of my colleagues say, I'm not even worried about the protein. What I'm worried about is the minerals. I just had a conversation with one of my colleagues that I am not encouraging more potassium with my patients on hemodialysis. I refuse. And so I think, okay, but let's look at the literature. We must always think forward. And when we're thinking about phosphorus, it's bound to phytate or phytic acid, and it has to be hydrolyzed to make it more bioavailable, to make it absorbed. How does that happen? It occurs through processing. It needs to be hydrolyzed. It needs to be more bioavailable, and that's done through soaking in an acid medium or lactic acid fermentation, such as yeasting. I like to mention this because I always get the question, what about yeast breads? That is a form of fermentation, right? Sprouting. And it is suggested that potassium in on-processed, excuse me, I'm talking too fast, I need to take a breath, in on-processed plant foods may not be greater than 60% absorbed. And that was documented by Picard in 2018. That to me is exciting. I love that because we need to include all those anti-inflammatory foods. And the pro tip, consider both the actual content and phosphorus in the food and the bioavailability of the various food sources. What in the world do I mean by bioavailability? Is it organic or is it inorganic? In other words, is it natural or not natural? If it's from a natural source, such as meats, fish, chicken, milk, that's going to be absorbed by 40 to 80%. If it's not if it's from a plant source, excuse me, then it's going to be absorbed 10 to 50%, partly because of what I said earlier, but it's the fiber. The fiber traps some of these minerals and it doesn't allow it to be absorbed, so it's going to be eliminated in the stool. Not just phosphorus, but selenium, chromium, molybdenum. It's a lot of these minerals will be eliminated in the stool because of fiber. So the higher the fiber, the better. That's kind of the secret. Also, too, I want to point out that if your patient is getting their protein sources from a vegetable source, they're not going to be getting the additives that are used, such as the potassium and phosphorus additive. That will not be playing a role in it. However, let me point out, devil's advocate here, if they're using meat analogs or fake meats, then think about that. When you start to manipulate the food source, you're making the foods more bioavailable. Also, too, there's going to be other things added like sodium, phosphorus, potassium, and typically fat. So those items are inorganic. Those salts are not protein bound. They readily dissociate in the gut, and they're going to be absorbed 90 to 100%. So that's the danger zone. And the pro tip is eat fresh, avoid the processed, ready to eat, or convenience foods. Avoid the additives and check the labels. In fact, the key in educating both ourselves and our patients is tried and true. Look for the hidden phosphorus by looking for the PHOS. There's been a wonderful study by Sullivan. I love it. It's one of my favorite studies, but we have to look for the PHOS on the food labels and the ingredient lists. And there's plenty of data on phosphorus. One of my favorite documentations is by Mo in 2010. This was a simple, very small, but effective because it's a crossover, and crossover studies are very easy to replicate. So that's why I love it so much. But CKD stage 3 and 4 patients were fed a vegetarian diet and then a meat-based diet. The phosphorus was equal in both groups, but the vegetarian group, they had reduced serum phosphorus and FGF23, which you see a higher FGF23 before you see a phosphorus. So that's why it's so important. And also urinary phosphorus excretion. And also too, noting in Azagbat, and I'm sorry if I'm saying it wrong, in 2009, even partial replacement of animal-based protein with plant-based protein results in decreased serum phosphorus in patients with CKD. And there are prospective, retrospective cohort studies that show that eating plant-based foods have significantly lower phosphorus levels in CKD. All of this data, again, is on reading list, and I want you to be sure that you have this. You can always reach out to me for more information. I won't leave you high and dry. But switching gears to potassium, we are no longer looking at keeping potassium within a tight frame. We are now just treating to keep serum potassium within a normal range. That is very refreshing. And St. Jules et al. Notes that although no studies show a difference between potassium levels in patients using plant versus animal sources, the alkalinizing effects of high potassium plant foods may explain the reductions in metabolic acidosis. And this is a very simple way of looking at it. If you're replacing meat with plant, meat is very high in potassium, so it's going to equal out. But if you're eating both meat and plant, it doesn't balance it out. So you got to kind of think of that in that sense. Potassium derived from plants promotes intracellular potassium distribution, such as the alkaline, the insulin stimulating, as well as promoting fecal excretion due to the fibers found in plant-based foods. So again, that's the key, the fiber. And there's growing evidence that plant-based nutrition, such as the DASH, the Mediterranean, may delay the progression to end-stage kidney disease, and that improves the survival. And for those patients that do exhibit hyperkalemia, there's the newer, once daily potassium binders that can keep potassium homeostasis while allowing patients to enjoy the benefits of this nutritional foods. Also, too, this is where it becomes very critical for a dietitian to play a role, because dietitians trained in CKD know the differences between all the stages in CKD and how to best optimize a patient's nutritional intake and teach them cooking strategies so that they know how best to handle this. The pro tip: fiber. Fiber increases stool quantity and frequency, which when excreted facilitates potassium excretion. But I want to talk a little bit more about this because potassium is most often misunderstood, and the concerns about hyperkalemia are overinflated. Then, although the plant-based items are usually the culprits. And why is that? It's usually the juices. Oftentimes it was my patients who were in a nursing home given orange juice to treat their sugar. Orange juice doesn't have fiber, so of course it's going to cause hyperkalemia, but it's usually, sauces, juices, dried fruit sometimes. But it's important to know it's the variance of fiber that impacts both the content and the phosphorus. But as an aside, let's look. What are the top 5 sources of potassium in a patient's diet? Beef, chicken, Mexican food, hamburgers, and legumes. And when we look at a high potassium food list, are the meats included? Typically not. If we look at the cutoff of a 200 milligram proportion, beef usually isn't on the list, but a T-bone, a 3-ounce T-bone is over 200 milligrams, and a pork chop is over 200 milligrams, but a kiwi is only 215 milligrams. So if we just balance that out, now kiwi isn't going to give protein, but legumes will. So if we just minus that, cross it over, it'll balance. But what I do want to point out is that there's non-dietary factors that do impact hyperkalemia, such as tissue breakdown, wounds, infections, prolonged fasting, hyperosmolality, constipation, and medications. So we need to think globally, as I always say. And just a snapshot view of some data looking at hyperkalemia in several studies. Pre-dialysis, you can see that there was no incidences of hyperkalemia except in one study by Morty, and that patient had 2 instances of hyperkalemia. What do you think he was eating? Edamame, tons of it. And once he was educated on that, it was resolved. But if you look at the observational studies with patients on hemodialysis, there was no instances of hyperkalemia, although thinking of this, some of these are rather small, but it's a start, and we have to start somewhere. And newer data presented at the NKF spring clinical meetings by Betts et al. Was an analysis to assess relationship between potassium intake and serum potassium levels. Found in patients with CKD, dietary potassium did not correlate with serum potassium or hyperkalemia. What was interesting is that patients in the top 50th percentile of whole grain intake were less likely to have hyperkalemia. And there was a sub-analysis in CKD 4 and 5, and it showed that dairy, potatoes, and tomatoes inversely correlated with serum potassium. I'm going to switch gears and talk about the gut just a little bit. When we look at the benefits of the plant-based diet with the gut, it favorably shifts gut bacteria from a proteolytic to a saccharolytic profile. And what happens when this occurs? We have an increase in short-chain fatty acids. The intestinal barrier integrity is strengthened. There's a reduction in inflammation, and the immunity is impacted. It's favorably improved. But this shift also reduces the production of key uremic toxins that are known to promote CKD, such as p-crystyl sulfate, indoxyl sulfate, indole-3 acetic acid, trimethylene, and oxide, which we know typically as TMAO, which TMAO is also a biomarker of both CKD and cardiovascular disease, and we now know it as a renal toxin. These uremic toxins are associated with animal protein intake. TMAO is especially associated with red meat intake, and they all favor the growth of proteolytic bacteria in the gut microbiome. We could spend an entire hour just talking about this. It's a great topic, and there's so much new data on this. And just a little bit more insight on this. Schiavarelli data in 2014 showed increased fiber in controlled feeding trials, and CKD reduced urea and creatinine levels in systematic review and meta-analysis. And Patel in 2012, with normal kidney function, there was 60% lower uremic toxins in p-cresyl sulfate and indoxyl sulfate in persons that were following a vegetarian intake versus omnivorous nutrition. And in a crossover study by Kandus in 2016, vegetarians undergoing renal replacement therapy, those versus non-vegetarians, those following a strict vegetarian diet, had a 47 and 67% lower indoxyl sulfate and p-cresyl sulfate, respectively. And there is additional data on your reading list, as I point out with other data. But what I do want to give you is a key takeaway. The effect of the fiber is multifactorial. It's not just the fiber, but it's both the fiber, the reduction of animal protein, and replacement of plant protein. So it's a combination effect. At this point, you're probably thinking, well, how do we do a plant protein diet with our patients? How does this all fit? It fits with this daily intake that was published by Dr. Joshi. And the daily servings would look something like this: 2 to 4 servings of fruits, 5 servings of non-starchy veggies, 2 servings of whole grains, starchy veggies, 3 servings of legumes, 2 to 3 servings of nuts and seeds. And you're probably thinking, oh my gosh, that's a lot of potassium. But remember, I said it's kind of a balancing act, because they would not be eating meat and dairy. And then to make sure that we're not facing hyperkalemia, we would not be having, the fruits and juices, high potassium juices, and highly processed foods. But here, the pro tip is education on portion sizes. What exactly is a serving size? And I find that that's often overlooked. In looking at any type of nutrition intervention, it does not matter what nutrition intervention we're looking at. We must focus on the readiness to change. We know that these plant-based diets they're not only adequate, but they're safe. But we must look at the step in change. They must desire a change and commit, and then establish goals, even small goals. And there's a tool to use, and it's looking at the 5 A's. It's a useful strategy, and looking at the willingness and appropriate change behaviors to incorporate a patient's willingness and readiness to change. And it looks something like this. The 5 A's are: assess, looking at the patient's beliefs, behaviors, and knowledge. Advise, we would look at giving a patient education on health risks and behavior benefits to change. And then agree. This is a collaboration between you and the patient, setting goals. I have a session just on this, looking at setting these goals not on your wants and needs, but on the patient's wants and needs. And also too, based on their interest and confidence, they have to know exactly how they feel they can fit this in. And then assist, identify the barriers, the strategies. This is a brainstorming session. This is when you really dig in. And then find out, what's their support system look like? And then arrange, identify, what is this going to look like? Is there going to be follow-up visits, text messages? Are we going to do reminders? Is it going to be by Zoom? Is it going to be by phone? Are you going to see them? But this self-management plan includes all the elements, and it's intended for use for improving chronic illness. And the pro tip, individualized care model. And what is most important about this? It's allowing patient autonomy for decision-making. And the tools that we would use are motivational interviewing with ORS, using open-ended questioning, affirmation, reflection, summarization, using SMART goals that consist of specific, measurable, attainable, realistic, and timely. And all of this incorporates medical nutrition therapy to slow the progression of disease and to provide quality of life. We have key takeaway messages. The low protein diet of largely plant-based allows kidney protection and is not only going to give the patient the key nutrients that they need, but we know that it's favorable in preserving kidney function. It has beneficial effects on the gut, and it can be easily incorporated into the new guidelines. But most importantly, it needs to be patient-driven to enhance quality of life. I thank you so much. It's been an absolute pleasure to be here with you.
AnnaMarie, I wanted to say thank you so much for this talk. It was wonderful. We do have questions and a lot of really nice positive comments, really wonderful information. We've run out of time to be able to answer questions, but I'm sure that you will get those questions and we will get answers to people. So again, thank you so much for your talk. It was very, very interesting and educational.
It's been a pleasure. Thank you so much.
You're welcome.